Carfilzomib, I think, plays a very key role in this space, although I will tell you it's evolving. And it's evolving because carfilzomib is being used more and more in the frontline setting. So it's sort of a moving target how we're approaching relapsed refractory disease. And what I mean by that is that once a patient develops refractoriness to a certain agent, obviously that's not an agent that we would use in subsequent settings. So if patients are getting more and more carfilzomib up front and they're becoming refractory to it, that first relapse, then obviously we wouldn't use a carfilzomib-based regimen. But assuming that patients have not progressed through a carfilzomib-based regimen, I think there's excellent data to use carfilzomib in patients who have already been exposed or even refractory to other proteasome inhibitors, including bortezomib. And the data that I'm going to talk about tonight suggests that that's absolutely the case. The ARROW study showed that giving once weekly carfilzomib at 70 milligrams per meter squared has actually superior efficacy towards versus twice weekly carfilzomib, which is given at 27 milligrams per meter squared on days 1, 2, 7, 8, 14, and 15. But interestingly, the downstream effect of that you would think would be increased toxicity, but it's actually quite the opposite. There was actually more toxicity with the twice weekly dosing versus the once weekly dosing. The only caveat to that is that there were more patients in the weekly dosing arm that had to have that dose reduction in their carfilzomib based on some degree of minor toxicity. But interestingly, yes, you see better efficacy and less toxicity. So I think there's great evidence to use the weekly dosing of carfilzomib, which obviously is more convenient for patients and allows them to have a little bit more freedom in their lives, which is always a good thing.